Can you see my screen? Okay, so I think we can start because we have a different session at 9, so I'd like us to cover as much as possible. Okay. So I think we did this yesterday, so we're just continuing. Mm, so yeah, so you'll be told to identify this. Can you see this? You'll be asked to identify this. So this is a Coombs reagent. Why? So it's usually green, or you can say anti-human globulin reagent. Okay. Now, so I want to take a minute to explain. I remember the first time when we were taught about the Coombs reagent in the hematology rotation. It was kind of a little bit tricky, but over time I got it. So maybe I can explain a few things. So in Coombs test, we have two tests. We have the direct Coombs test and the indirect Coombs test, isn't it? So how are they different? So let's start with the direct Coombs test. So in the direct Coombs test, we detect antibodies or complement on the surface of red blood cells. So that's the most important statement I want you to remember. We detect antibodies or complement on the surface of red blood cells. Okay. And in indirect, we detect antibodies in the serum. So serum is the liquid part of blood. Okay. Yeah. So I've said indirect, we detect antibodies on the surface of RBCs, and indirect, we detect antibodies in the serum. So how is the direct Coombs test done? So basically, we have the patient's red blood cells because we want to take the antibodies on the surface of red blood cells. So we need the patient's RBCs, and then we add it to the Coombs reagent, okay? So when you add it to the Coombs reagent, if there's a reaction, it's positive. If there's no reaction, it is a negative. So you might ask yourself, what is this Coombs reagent? So anti-human globulin, what is it, isn't it? So basically, these are antibodies against the human globulin. So the human globulin, so it could be IgG, IgM, or even complement, okay? So, for example, we have red blood cells. I want you to picture in your mind, we have red blood cells. And then on the surface, we have the antigen and the antibody, okay? Now, if you have an antibody on the surface of red blood cells, it will come react with the antibody of the Coombs reagent, okay? So when that happens, there'll be agglutination and then there'll be a positive test, okay? That's for the direct one. For the indirect one, which I find to be easier, you just detect the presence of antibodies in the serum. So you take the patient's plasma, with known antigens, and then you add the Coombs reagent. If you add the Coombs reagent, we'll see a positive test, okay? So I think you've got the difference between those two. That's usually the main thing, okay? So for the indirect, as I've said, the antibodies are in the serum, so they're just floating around inside the serum, okay? Yeah. So if you ask, explain the use of the Coombs reagent in a transfusion practice. So from that, this is the best summary. It is used for both direct and indirect Coombs test to detect the presence of incomplete antibodies on sensitized red blood cells, okay? That's how best I can summarize what I've been saying, okay? So, and then 3 conditions in which Coombs test is positive: transfusion reactions, autoimmune hemolytic anemia, hemolytic disease of the newborn, drug-induced immune-mediated hemolysis. So I want to ask you questions. Let's start with transfusion reaction. Which Coombs test do you think it is? Is it the direct or the indirect from what I've explained? I want to see some answers in the chat. Transfusion reaction. So I'm seeing someone has said a direct Coombs test. So for transfusion reaction, let me see another answer. Direct. I'm seeing someone else has told me indirect. Okay. So let me repeat. For transfusion reaction, we have for transfusion reaction, so it depends. So I receive blood from a donor, isn't it? And the donor is giving me RBCs, isn't it? So are we checking antibodies in your serum or antibodies on the surface of the RBCs? Yeah. So we're checking antibodies on the surface of RBCs. You have seen someone has written there. So for the transfusion reaction, it's a direct test. Okay. Autoimmune hemolytic anemia, which is it direct or indirect? I see someone has said direct, so yes, autoimmune hemolytic anemia. Hemolytic disease of the newborn. So for hemolytic disease of the newborn, is it direct or indirect? So let me make it simpler. When we use the serum of the mother, do we do an indirect Coombs or a direct Coombs? And when we use the red blood cells of the child, do we use a direct Coombs or an indirect Coombs? So, okay, so you can type on the chat. So mother direct or mother indirect, child direct or child indirect or direct. Mother indirect, baby direct, child indirect, mother direct, mother indirect. So remember, in the mother, we are using the serum of the mother. So if you're using the serum of the mother, we want to see if there's antibodies on the serum. So it will be an indirect test, okay? And for the child, we are using the red blood cells of the child. And if you're using the red blood cells of the child, we want to see if there are antibodies on the surface of the red blood cells. So it will be a direct test. So mother is indirect, child is direct. Okay? It can be a little bit confusing, but if you understand the concept, it will be way better. Okay? Yeah. When you do cross-matching, it's usually indirect Coombs. Prenatal antibody screening, indirect Coombs. Okay? Yeah, so the Coombs test is a little bit difficult, but if you understand the concept, it will be better. Someone is saying repeat. Oh, so I repeat the one for the hemolytic disease of the newborn. Okay, so for hemolytic disease of the newborn, we use the serum of the mother. And as we said, in indirect, we are detecting antibodies in the serum. Okay, so that is an indirect Coombs test. Okay, but for the baby, the child, we're using RBCs of the child, the red blood cells of the child. And if you're using RBCs of the child, it is direct Coombs, because we said direct Coombs, we're detecting antibodies or complement on the surface of RBCs. Okay, so that's how I differentiate it. I'll look for a nice video I watched, and then I can send it to the group. It gives a good explanation on the difference between direct and indirect and ways it is used. But it's, yeah, okay. And then ABO blood grouping. So this is also another topic which is very high yield. So you have a group like this. So we have P, there's cells and there's serum. So you have to understand what is in the cells, what is in the serum, okay? So let's see. So I'd like you guys to attempt PQRS. What is PQRNS? So that I can see. So to give you a hint, in the serum, we have antibodies, okay? And in the cells, we have antigens on the surface of the red blood cells, okay? So cells are basically the red blood cells. Then serum is the liquid part of blood, which we have the antibodies, okay? So if you see A, it actually means antibody A. If you see B, antibody B. If you see O, it should actually mean anti-A and anti-B, but, or it can mean any other antigens, because, any other antibodies. So basically this O, it's in a chart like this, it's rarely, it's the significance of O is not that important. Like you can do away with this this column. Then anti-D, this is the rhesus antigen. Okay. So what do you think P is? So P, negative, 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 then positive. Q. Anyone on the chat who's going to type? For P alone. P O positive, yeah. So how did you get through it? So we said the cells are the antigens on the surface of red blood cells, and the serum is the antibodies. So you ask yourself, so A, antibody A was negative. So you know that is not A, because antibody A will react with antigen A, and the reaction is negative, so it's not A. B, antibody B will react with antigen B, and if it's negative, meaning there's no reaction, so it's not B. O, negative, so this one I told you this is not relevant. Anti-D, there was a reaction, so meaning there was a presence of rhesus antigen on the surface, on the cells. So this is O. So if it's not A, B, it's O positive. Okay. For Q, so I said serum is antibodies. Antibody A reacted with the antigen A. So there was a positive reaction on the cells. So it is A, it has to be A. Then B, serum, I said serum has antibodies. So antibody B reacted with the antigen B on this Q cell. So it is AB. And then anti-D, it was negative. So the rhesus, there was a negative rhesus. So that is AB negative. Okay. So Q is AB negative. R, same principle. Antibody A didn't react with antigen A, so the negative reaction. Antibody B didn't react with antigen B, so no reaction. So if it's that's an O, and then there was no rhesus reaction, so that's an O, negative. Antibody A reacted with antigen A, so that it should be A. Then B, antibody B did not react with antigen B, so that's negative, so it's A. And if there was a positive reaction with anti-D, so that's A positive. So S is A positive. So which type of blood grouping is this? So is it a forward one or is it reverse? Forward, but you're not sure. So so this is a forward grouping. So why is it forward? In forward, we use the serum, okay, to determine the antigens on the surface of the RBCs. So we already know the serum, we don't know the cells. So we are using the serum to determine the antigens on the RBCs, okay? For reverse, we use the cells. So if the cells were here, we knew the cells to identify the presence of antibodies on the serum. Yeah, I've never seen them testing reverse, like from the past papers or anything, but in case they interchange these two, you have to be very keen. So because sport is a very high intensity, you have one minute to see. If you just see serum here and cells here, that's forward. How I used it in the previous exam, how I remembered, if I saw serum here and cells here, if you don't have like time to think, to reason out, I don't know, if there's no reaction between A and B, that's an O positive. If there was a reaction with A and B, that's an AB, then you look at anti-D, negative. If there was no reaction A-B, that's an O, negative. If there's a reaction at A, B was negative, O is negative, this is an A, positive. That's if it's cells and serum. But they may be tricky and interchange. So if they interchange, I'll look for a question I see, then I can add it in these slides so that we can analyze it. But I hope you've understood this forward grouping. Then list 3 risks associated with transfusion practice. 3 risks associated with blood transfusion practice. So there are a lot. Blood transfusion reaction, acute and delayed, iron overload, transmission of infections. I took a screenshot from the notes. I actually saw this is a potential essay question, so they can tell you 10 marks. So you have to know all this. So immediate stroke acute adverse reactions. So here they are, then the delayed ones. So the immediate ones, acute hemolytic transfusion reaction. So hemolysis can occur. Febrile and hemolytic transfusion reaction, allergic reaction, urticarial, anaphylactic. Then we have TACO, transfusion-associated circulatory overload, non-immune red cell hemolysis, TRALI, transfusion-related acute lung injury, septic transfusion reaction, hypotensive reaction, ACE inhibitors, metabolic disturbances, hypothermia, hyperkalemia. Then the delayed ones that can occur later, delayed hemolytic transfusion reactions. So we have alloimmunization, graft versus host disease, post-transfusion purpura, hemosiderosis, viral and parasitic infections, transfusion-related immunomodulation. Okay, so this table is a very high-yield table. It can come as an essay question. So you look at that. So we have blood staining. I don't know. Can you see well? This. Can you identify? Name the preparation. What preparation is this? So they're basically asking the preparation. So nothing to do with what's inside the slides, just this preparation. So who can name the preparation? Anyone on the chat? Don't overthink. It's a very simple question. And they're just asking about the preparation. Yeah, PBF. So it's a peripheral blood film. Okay. Yeah, so this is a PBF. That's how it's seen under light microscope. And then give two uses of the procedure in hematology. So quite a lot. But the main ones I remember. So one, you can say it shows anisocytosis. And remember yesterday we said anisocytosis is difference in sizes. And then it shows poikilocytosis, which is PP for difference in shapes. And then it can show the presence of parasites. So for example, malaria. Okay. Yeah. Then two abnormalities shown in the plate. It's not that clear, but at least this one you can see. So this is a cell and there's so many lobes you can see here. So if you have to count 1, 2, 3, 4, 5, 6. So you can know this is a hypersegmented neutrophil. Then this one looks like a target cell. This one here. Which other one? This one looks like a teardrop. This one looks like a very large cell. So macrovalocyte. Yeah. So those are the abnormalities you can see there. Yeah. So blood products. So state 5 products that can be prepared from the spot. So this, give the storage conditions and shelf life of each product. So this is also a common question. It comes in rotations. It comes in a spot. So we can go, maybe you can state them on the chart, then we go through them. Which blood products? FFP, yes. Factor RBC, platelet concentrate, cryoprecipitate. Yeah, there are a lot. So 5 products. I usually like to go in an order that I can remember. So the first one, which FFP, fresh frozen plasma. Plasma. So to remember the uses, you have to remember what does it contain. Okay, FFP, fresh frozen plasma. What does fresh frozen plasma contain? So plasma, one, it must contain the coagulation factors. So it contains all coagulation factors. All the factors you can think about. Factor 1, 2, 3, 4, 5, till 12. Okay, till 13. Okay. And the plasma proteins. Okay. So you think of conditions you may use. Liver disease. Why do you use it in liver disease? Remember, where are these factors produced? In the liver. So if someone has a liver disease or maybe liver cirrhosis, you give them FFP because of it contains all the factors. Yeah. TIC, vitamin K deficiency, renal disease. Okay. Cryoprecipitate. It's supposed to be cryo, not cryo. Cryoprecipitate. You ask yourself, what does it contain? Factor 8. So factor 8. So hemophilia. Factor 8. Factor 13. So it's usually 8, 13. VWF. It contains VWF. So for von Willebrand's disease, VWF. It also contains fibronectin and also fibrinogen. Okay, so I've said fibrinogen, factor 8, factor 13, fibronectin, and BWF. Okay, so you can also add hypofibrinogenemia in the list. Okay, platelet concentrate, from the word platelet concentrate. Oh, storage condition -20 for 1 year, same to FFP. Platelet concentrate 22 to 25 degrees. So this is basically room temperature. It contains platelet. So to correct thrombocytopenia. And you remember yesterday we talked about thrombocytopenia in depth. Yeah, so EG in acute leukemia. And you remember it's only for 5 days. Okay. And you remember the platelet should be placed in a platelet aggregator to keep it moving. Okay. WBC concentrate, 2024, so almost like room temperature for 24 hours. Immunosuppression, burns, yeah. Packed RBCs, 2 to 8 degrees for 35 days in CPDA. So you have to mention, so because you see they asked storage and shelf lives. So you have to mention 35 days in CPDA, 2 to 8 degrees. So sickle cell crisis, acute blood loss, maybe severe anemia. Yeah, there are so many things. So I just mentioned one. So this table is very high yield. So you have to know this. Okay. At least I've tried explaining. Yeah. So identify the following. The following images are from the notes, so they can also come. So what is this? You can try on the chat. What is this? Okay, let me give you a hint. This is a knee. And they're draining something here. This guy is draining something from this knee. I think that gives you a hint. What is this? Hematology, yeah. So I gave you the hint. Hematology. So there was bleeding at the knee joint. So hematology. What is this? So there's a collection of blood under the skin. I think I had mentioned this yesterday. Hematoma, yes, yes, this I had mentioned. So these are hematoma because of the collection of blood. Good. What is this? Oh, I've already showed you. Petechiae, I had mentioned. You remember? They should be around purplish, reddish papules around the skin. What is this? If that is petechia, you should know this. I had mentioned yesterday. Pupura, yeah. Why pupura? Because we said petechia, so a bigger petechia is there. Pupura. Then this. So this one is collection of blood. You can see it's not that deep like a hematoma. It's like at the surface of the skin, like just beneath. Ecchymosis, yeah. Ecchymosis. So for these questions, you might be brought this, and then you ask relevant questions about it. Okay. I think we discussed that yesterday about thrombocytopenia. And remember, I told you petechia is not a coagulation disorder. Note that. Don't forget that. What is this? What is this? What is this? What is this?
I have a question about the previous slide.
Okay, yes.
How come yesterday you told us not to say hematolosis, we say swollen knee, and then today we are saying hematolosis?
Oh, so for yesterday, If I can go back to that question. Let me go back to the question. So if you're asked to state the abnormality here, you say swollen knee. Okay? But for this, most likely, okay, if they ask, they'll ask you what is the condition. Okay? There's that picture here. Look at this. If they ask you what is the condition, and okay, so if in the previous question they asked what is the abnormality, what do you see? Similar to that one, or for Burkitt's lymphoma, they'll ask you what is the abnormality. If they ask what is the abnormality, you just say swollen jaw or swollen jaw mass, swollen knee. But here they might ask you what is the condition being represented. And this one, they made it very obvious by showing that this person is drawing blood from the knee. So you'll say hematology. Okay. Hope I've answered your question. Yeah, so we were here. Have you ever seen this cell? Yeah, so I'm seeing someone saying lymphoblast, smart cell, yes. So the cell being pointed at is this one, not this, okay? This is the cell being pointed at. Can you see this arrow? So this arrow is pointing at the smudge cell, not this. But this is a lymphoblast, okay? So don't confuse. So this is a smudge cell. Which conditions are smudge cell usually seen in? Usually seen in one major condition. Smudge cell. Have you ever heard of smudge cell? Which condition is it normally seen in? Also, I'm seeing someone has texted me. ALL. So ALL, you'll see lymphoblasts, not smudge cells. So for smudge cells, okay, we see in CLL. Yes, CLL. CLL, okay? So identify the neoplasm, chronic lymphocytic leukemia or CLL, and state its marker. So if you remember, CLL is a lymphoid neoplasm, and it's usually positive for B cell markers. So CD20, CD23, CD5, okay? And one thing you'll also remember that CLL occurs in elderly people, so greater than 60 years. And yeah, and it is anything else to remember about it? It transforms into an aggressive lymphoma. If they ask which one is the most common, diffuse large B-cell lymphoma, okay? DLBCL, diffuse large cell B-cell lymphoma, okay? Yeah, anything else about it? Yeah, that's what I can remember. So if you see this smudge cell and the lymphoblast, so this is CLL because of, so basically these cells smudge during preparation. So that's why they're known as smudge cells. Okay. Yeah. So hemostasis, examine coagulation test results of an 18-year-old presenting with bleeding disorder. Prothrombin time, 14. Control is 13. APTT, 70. APTT control is 33. Bleeding time is 14. So before we even answer this question, we can interpret the data. So the is the PTT elevated or is it? So it's within range, isn't it? The prothrombin time, PT, sorry. Then the APTT, 70 and 33, elevated. Bleeding time. So notice they've told you IVs, and you have to know IVs. IVs, APTT high, yes. So for IVs is 7 minutes. Dukes, 5 minutes. Okay? You have to remember that. I think I've also written down. Bleeding time, IVs, maximum 7 minutes. Standard IVs template method, 9 minutes. Dukes, 5 minutes. Then PT against control, maximum difference, 3 seconds. So that was 1 second, which was okay. APTT, 10 seconds. Thrombin time against control, 2 seconds. Now, comment on the results. So we have commented. State with reasons a congenital disorder that can give to such results. So think about it. You have a high bleeding time and a very high APTT. So is this a coagulation disorder? So are we affecting coagulation disorder, or are we affecting the platelets? What are we affecting here? VWD, yes. So that's the first thing you have to remember. If you see prolonged bleeding time, you know you're affecting the platelets. Okay. Then APTT, we remembered we said playing table tennis is done inside. So it is an intrinsic pathway. And here the most likely factor affected is factor 8, because we know VWD binds to factor 8. Yes. So you've been told, state with reasons a congenital disorder that can give such a result. So you have to give a reason. Why is there prolonged bleeding time? So as I've told you, VWD binds to factor 8. So here, in VWD, the pathogenesis of VWD, so there's 2 pathogenesis. One, either you have low levels of VWF, von Willebrand's factor, or the von Willebrand's factor is not functioning properly. Okay, so what will happen? For the prolonged bleeding time, the platelet addition is not functional. So what will happen? You'll have an impaired primary clot. Okay. And number 2, for the prolonged APTT, we said VWF binds factor 8. And if you reduce the binding, what will happen? You'll prolong the bleeding time. So basically, here's the explanation. Impaired primary clot formation due to dysfunctional platelet adhesion, hence a prolonged bleeding time. Reduced binding of factor 8, reducing its activity, hence a prolonged APTT. So I think that makes sense. Petechiae. So these spots. So you'll be asked what's the clinical feature we have seen up there. So it's petechiae. Then what are the other 2 associated clinical symptoms? So I tried to divide them in based on the organ it affects. So CNS, you'll expect seizures, stroke, GIT, bowel ischemia, renal. So it should be chronic kidney disease, end-stage renal disease, liver, hepatomegaly. This one we did it yesterday. Then I hope that's clear. Then the dry blood spot. Oh, this is immunology, but I put it here under hematology. I don't know why, but we can still do it. You'll be told to name the item. This is a dry blood spot. Basically, how it's prepared is they take a sample of blood and then they dry it into this this filler paper. So this filler paper, it will absorb the blood, making it dry out. Okay. Uses. What can you think of the uses? So this one you have to know. If you don't know, you don't know. You can't, I doubt, if you've never seen this, you can't think about it. So the uses: transport of blood for DNA analysis, neonatal HIV testing using PCR, and then high profile lipid chromatography, HPLC, as we mentioned yesterday. Okay. And then this. So results from a 6-year-old boy recently treated with antibiotic for tonsillitis. What lab tests should be ordered to determine if the anemia is due to an antibody? If you just hear the word antibody, this one should give you a clue. It has to be a Coombs test. And which one did we say we do? Presence of antibody on the serum. Is it direct or indirect? Indirect. And which one did we say we check for the cells? Antigens on this, antibodies on the surface of RBCs. Direct, yeah. So at least you understood that. So that's a high-yield concept to understand. So for this one, do we use direct or indirect? So HP, so this guy has anemia, indirect bilirubin, 55. So that tells you there's hemolysis occurring. So as we mentioned previously, so which ones do we check about hemolysis? As we mentioned earlier, direct, yes. Okay. Yeah, so you get the hang of it. So we use direct. So we want to know if it's drug-induced hemolysis or autoimmune hemolysis, maybe alloimmune hemolysis, okay? So what does the test detect? It detects antibodies attached to the surface, to antigens on the surface of red blood cells, yeah. Then flow cytometry. So I put this is also immunology, but I put it here. So one thing I want you guys to go do is to write applications of, so it must either come in immunology. Number 1, flow cytometry. Number 2, ELISA. Number 3, PCR. You see those 3 things? One of them should come, must come. They'll ask you. They might give you a diagram for you to see. So maybe a flow cytometer, or they give you the ELISA or the PCR, or they just ask you list 2 applications of flow cytometry, or list 3, list 4. Yeah, flow cytometry, ELISA, PCR, that one. You already have 3 marks from immunology. Okay. Yeah, so there are a lot. These are just some immunophenotyping for leukemia and lymphoma, HLA typing and cross-matching for solid organ transplant, quantification of CD4 T cells in HIV patients, cell sorting, detection of HbF, so fetal hemoglobin, positive cells in fetal maternal hemorrhage, cell cycle analysis, apoptosis assessment. There are quite a lot. These are just a few that I got. So if you're told to list, the ones that I remember writing in the exams, immunophenotyping for leukemia and lymphoma, cell sorting and quantification of CD4 positive T cells in HIV. Those ones are the ones I can remember. Okay, so flow cytometry, PCR, ELISA, very high yield. So look at these spots from this patient. So you'd be given a history, adult male with immunosuppression and progressive nodular lesions on the lower limb. Biopsy taken at histopathology shows spindle cell neoplasm forming vascular channels and extravasation of red blood cells. Regression noted in the start of ARV. So that is there it is. Spindle cell neoplasm forming vascular channels and extravasation of red cells. There is the answer. So this is Kaposi. Even if you weren't given this picture and just told this history, you'd know it's Kaposi sarcoma. Okay. For example, this can come in an MCQ. Okay. So you have to be, this is more of, it looks like an adpatho-ish. Yeah. An adpatho-ish, especially under histopathology. Yeah. But if you just see spindle cell neoplasm form vascular channels and extravasation on red cells, that is Kaposi sarcoma. HHV8, herpes virus 8. Okay. And on start of ARV, so the patient is on ARV, so the patient has HIV. Most likely what you'll note is the CD4 cells, CD4 count is less than 500 in this patient. Okay. So that's Kaposi sarcoma. You can be given another one. Another one I can remember is you're told, maybe you're given a history, the patient is on ARVs, and then you're told on histopathology, you see, oh no, sorry, not on histopathology. On examination, you see maybe multiple red to purple papules or nodules. And then in biopsy, when you take biopsy, you see neutrophilic inflammation. And the patient is regression noted on the start of ARV treatment. What is the most likely diagnosis? Have you heard me? You told the patient has multiple red to purple papules or nodules, biopsy with neutrophilic inflammation, regression noted on the start of ARV treatment. So yeah, so that one I'll give you to go check. If you get the answer, you'll tell me. Okay. Let's continue. Microcytic hypochromic anemia. A 30-year-old male presented with hematemesis and microcytic hypochromic anemia. Give two possible differentials. So when you see hematemesis, so this is bleeding, vomit, so vomiting blood, okay? And microcytic hypochromic anemia. So you think of peptic ulcer disease, which can present with so peptic ulcer disease, so lacerations will cause the hematemesis. Mallory Weiss, this is an adpatho. The lacerations in the esophagus. Ruptured esophageal varices, so most likely due to portal hypotension. Gastritis, so inflammation of the stomach. Ancylostoma duodenale or hookworms, so during migration. Okay, then what specimen would help confirm diagnosis? Gastric biopsy and stool, so stool in case of the hookworms. Then cell, so multiple nodules. This is a neutrophil. Causes of its decrease. So similar to this. And then another thing I'd like you to go check, it's in this PDF, but I've not yet organized it well, is you check monocytes, lymphocytes, basophils, neutrophils, eosinophils, and yeah, I think I've said all of them. You go check causes of its increase and decrease. But I already gave you a formula to know for decrease. Decrease, remember to say aplastic anemia in all, chemotherapy, HIV, except eosinophils, and yeah. So if you say, you can say, if you say aplastic anemia, you can also say Fanconi anemia and myelodysplastic syndrome. Make sure you just don't write bone marrow failure, because you'll be limiting your answers, okay? So that I've already given you a formula for decrease. Now go look for the increase. Like monocytosis, you expect malaria. Neutrophils, you'll expect a viral infection. Sorry, neutrophils, a pyogenic infection. You see, so those specific cells. Basophils, you'll expect allergy. Okay, so that's how it is. But I've already made your work easier by saying the decrease. you'll have to remember this: myelodysplasia, chemotherapy. Also, you can add here HIV and aplastic anemia. You see, you already have around 4. And then these are the other ones, but they're specific to neutrophils. Shida Higashi, severe sepsis, viral infection. Yeah, I think I want to stop there. There's someone who's going to lead you through the MCQs. Let me inform them. So the person recording, you can stop share.